In the second section of our lecture, Congenital Malformations, now we will talk about the vaginal maldevelopments. In this section, we will talk about pathology of Mullerian malformation, partial agenesis of upper vagina, and also besides the partial agenesis, we will also talk about the complete agenesis of the vagina. Vaginal maldevelopments, there is agenesis of the vagina, and there is failure of vertical fusion and failure of lateral fusion. And also the causes of vaginal maldevelopments are usually maybe polygenic, multifactorial, teratogens, or environmental. So in this diagram, if you see, we have different vaginal maldevelopments like agenesis. Agenesis is if there is a failure of Mullerian duct development, it leads to Mullerian agenesis. That is the agenesis of the vagina. Then also Asherman syndrome, in which we have intrauterine adhesions. Intrauterine adhesions, if you see in this diagram, in Asherman syndrome, there are adhesions in the uterus, and these adhesions can lead to infertility because of the narrowing of the uterine cavity. Also, we have cervical stenosis, in which there is narrowing. Stenosis is the narrowing of the cervix. Cervix is the opening of the uterus, lower part of the uterus, and it is, if there is stenosis of the uterus, it also can lead to infertility. Cervical stenosis. Then we have the transverse vaginal septum. Here, if you see, this is the transverse vaginal septum. There is a septum in the vagina that lies transversely. Imperforate hymen, we already talked about the imperforate hymen, so that's also the maldevelopment of the vagina. And then we have labial fusion agglutination, that's another vaginal maldevelopment. So it can be agenesis of the vagina, agenesis, failure of the vertical fusion. We have vertical fusion. So if there is vertical failure of the vertical fusion, it also leads to vaginal maldevelopments. And lateral fusions. Lateral fusions can also lead to maldevelopment. So all the causes can be teratogenic. Different drugs can be teratogenic, or they can cause abnormalities like DES, diethylstilbestrol. It has teratogenic effect, which is used for as an abortifacient. There is also some environmental factors can lead to vaginal maldevelopment, and there might be congenital, hereditary, or genetic factors. So all these can lead to vaginal maldevelopment. Next was the pathology of Mullerian malformation. Vertical fusion defects like failure of fusion of Mullerian system with urogenital sinus. This leads to vertical fusion defect. Disorder of lateral fusion is due to failure of two Mullerian ducts to unite. So as we talked in the previous slide, that some disorders that can lead to vaginal maldevelopments, we have vertical fusion defect, we have lateral fusion defects. Now, vertical fusion defects are due to failure of fusion of Mullerian system or Mullerian duct with urogenital sinus. And then, as the name shows, lateral fusion defects are due to failure of the fusion of Mullerian ducts, two Mullerian ducts with each other. Then the transverse vaginal septa. Transverse vaginal septa is due to faulty fusion or canalization of urogenital sinus and Mullerian duct. All these Mullerian system and urogenital ducts, all these are the structures which during the embryonic period develop into the female genital structures. So failure of canalization, failure of fusion of the Mullerian duct or Mullerian system can lead to different malformations and maldevelopment. This is like a bicornuate uterus. If you see, the uterus has two cornua, so this is bicornuate uterus. Longitudinal septum, how we develop the longitudinal vaginal septum. Transverse vaginal septum is this, longitudinal in this direction, so it's the distal part of Mullerian duct fail to fuse. So if the distal part of the Mullerian duct fail to fuse, they lead to longitudinal septum. Treatment is ultrasonography, treatment of the septum in the upper vagina and abdomino-vaginal approach. So treatment can be by ultrasonography diagnosis, septum in the upper vagina and abdomino-vaginal approach. Now the partial agenesis of the upper vagina. Associated partial agenesis means it's not a complete absence, there is just the partial agenesis, and that agenesis is present in the upper part of the vagina. How this, what leads to partial agenesis? It is associated with hypoplasia or even absence of the cervix. Hypoplasia. The cells do not develop or grow properly, so it leads to hypoplasia. And there is absence cervix and vagina, agenesis, upper vagina. Uterus may be normal and functioning or malformed. It's not, has to be abnormal. So it may be normal or it may be malformed. It's not always malformed. So in the partial agenesis of upper vagina, there is agenesis of the upper vagina along with the sometimes absence of the cervix. The uterus may be normal functioning or it may be malformed. So here, this is the upper vagina, and the upper vagina is there is agenesis of upper vagina along with the absence of the cervix. Primary amenorrhea, hematometra, hematocolpus, cyclic lower abdominal pain and lower abdominal mass is present in agenesis of the upper vagina. So amenorrhea, absence of menstruation, or there is collection of blood in the uterus. Here in this picture you can see it's hematometra, or there is collection of blood in the vagina. So all this, there is also lower abdominal pain and tenderness. So symptoms are more or less as the imperforate hymen, and there is a lower abdominal pain and also lower abdominal mass. So partial agenesis of the upper vagina. All treatment is by hysterectomy. Now the complete agenesis. Complete agenesis means complete absence associated with absence of uterus, presence of healthy gonads and fallopian tube. So complete agenesis is there is, as we saw in the partial agenesis, there is uterus is normal or maybe malformed, but uterus is present. But in complete agenesis, uterus is absent, but gonads and fallopian tubes are present. In female, the gonads are ovaries, so ovaries are present. So there is absence of the uterus. Urinary tract and skeletal malformations are also present along with complete agenesis. Treatment is a non-surgical method, and in the non-surgical method, since there is no uterus, no vagina, it's agenesis, so the aim is to create opening. So use of graduated vaginal dilators for 6 to 12 months. So the dilators are used starting from the low numbers, slowly increased in number, to the aim is to obtain a opening, and it should be done for a period of 6 to 12 months. Then we have surgical treatment in which different procedures are tried, in which we have McLindoy-Reed procedure, Williams vulvovaginoplasty, and vaginoplasty with amnion graft. So in these different procedures are tried in which the pouch or opening is created, lined with the skin, like in the McLindoy-Reed procedures, and the pouch is created, and then it is grafted with the skin, and the graft is removed from the patient's own body. So these are the different procedures, non-surgical and surgical. So complete agenesis and partial agenesis. Partial, we have upper vagina absent, cervix absent, but uterus is normal or maybe malformed. In complete agenesis, there is absence of the uterus also, but gonads are present, so hormones are being secreted, and then fallopian tubes are also present. Treatment can be by non-surgical methods in which dilators are used for 6 to 12 months. It's not very comfortable procedure. Patient depends on the outcome, depends on the compliance of the patient, because patients are not comfortable with this procedure, so they keep missing the appointments. But the other is the surgical approach, in which the cavity or opening is created. So that was all about some other vaginal malformations, in which we talked about partial and complete agenesis. Thank you for watching sqadia.com.